Hello everyone, thank you for joining. Today we explore the journey from pressure to protection, focusing on hypertension management, especially in the context of kidney health. Here is a 35-year-old man who has newly developed hypertension. This is a typical patient many of us see regularly, young, asymptomatic, but now at risk. The key question posed is not just about controlling his blood pressure today, but about long-term kidney protection. How do we preserve his kidney function over the next 35 years? Hypertension, if it is not well managed, it is a silent and progressive contributor to kidney damage. That is exactly why early intervention is the key and very crucial. We should always remember that therapeutic decisions today will have consequences later. Here is a middle-aged man who, like the previous 35-year-old patient, started with de novo hypertension. But now he presents with elevated serum creatinine, 2.3 milligrams percentage, bilaterally small kidneys suggesting chronic irreversible structural kidney injury, likely because of chronic hypertensive nephrosclerosis or hypertensive CKD that we call. So the clinical message here is that this is the natural history of poorly controlled or late detected hypertension. He may not have had alarming symptoms earlier, but silently the kidneys have progressed to chronic damage. Bilaterally small kidneys confirms chronicity and limited regenerative capacity along with increased risk for end-stage kidney disease. What can we do now to slow or halt further progression of chronic kidney disease? It is also important to understand that even after structural kidney damage, aggressive blood pressure control and renoprotective strategies can meaningfully delay dialysis or end-stage kidney disease. How frequently do you see hypertensive kidney damage in young patients, say below 50 years in your own practice? For example, how often do you find young hypertensive already with albuminuria, mildly raised creatinine, or even slightly small kidneys on ultrasound? Exactly. Many of us have seen this scenario. The reality is, hypertension is not always just a cardiovascular issue. The kidney often becomes one of the earliest silent victims. In fact, in India and many low and middle income countries, we are increasingly seeing young hypertensives with early nephrosclerosis. And unfortunately, many of these go unrecognized until late stages of the disease. And this is exactly the problem. The kidney is both a culprit and a victim. Many forms of primary kidney disease cause hypertension, but equally, chronic hypertension causes progressive, irreversible damage to the kidneys. This two-way relationship makes it all the more important for us as nephrologists to focus not just on lowering the blood pressure numbers, but also on protecting kidney function much earlier. Continuous protection is also important, and aggressive protection of kidney function is also equally important. One of the most important mechanisms the kidneys use to regulate blood pressure is pressure natriuresis. As blood pressure rises, kidneys normally respond by increasing sodium excretion to reduce the intravascular volume and restore the blood pressure to normal. But as we all know, in elderly individuals and CKD patients, this response gets blunted. The damaged kidneys cannot effectively eliminate sodium, leading to persistent hypertension and volume overload. This slide shows the classical consequence of events we encounter in hypertensive nephrosclerosis. Even sustained mild to moderate hypertension sets off this cascade, starting with arteriolar narrowing, progressing to glomerular ischemia and collapse, and ending with irreversible nephron loss. By the time serum creatinine starts rising, significant irreversible nephron loss has already occurred. This silent but relentless progression highlights why early aggressive control of blood pressure and salt intake is absolutely critical to safeguard our kidneys. Now that we have seen how hypertension can damage kidneys over time, the next question is, which hypertensive patients are most at risk for early kidney involvement? Younger individuals with early onset hypertension need careful evaluation. Some may have genetic predisposition or secondary causes. Ethical and racial differences play a significant role. For instance, South Asians, including our population, show higher salt sensitivity and adrenergic tone, making them vulnerable. Diabetes, of course, is a potent accelerator of hypertensive nephropathy. And finally, patients who already have CKD, in these individuals, even mild blood pressure elevation leads to rapid decline in kidney function. So recognizing these high-risk groups early allows us to intervene aggressively, tailor treatment, and preserve kidney function longer. Now let's talk about why we in India need to worry even more. Studies have shown that around 60% of hypertensive Indians are salt sensitive, meaning even small excesses of salt intake translates into significant blood pressure rise. In younger individuals, elevated sympathetic overdrive is very common, seen in about 62%, leading to adrenergic hypertension with high variability, heart rate elevations, and organ damage. And of course, India remains the diabetic capital, with 37% of diabetics also having hypertension, creating a dangerous combination for the kidneys. So these three characteristics, salt sensitive, adrenergic, and diabetic, define why we need aggressive individualized hypertension management strategies for our population. Also, to summarize, our hypertensive patients in India face a uniquely dangerous cocktail of risk factors. Diabetes prevalence remains high, as already discussed. Salt sensitivity and high sodium intake is widespread. Rising obesity, cultural dietary habits with high salt diet again, and rampant use of NSAIDs silently damages the kidneys further. We also have regional variations, the so-called CKD-U belts, where environmental exposures may independently drive high CKD prevalence. All of this explains why we often see kidney involvement much earlier, even at mild levels of hypertension. So our approach to BP control in India cannot just be one size fits all. We need to be far more aggressive in surveillance, early intervention, and organ protection. Even after identifying our high-risk hypertensive patients, we must be very careful about how we assess their blood pressure. As you see in this image, standardized office blood pressure measurement is not always what we do in real-life busy clinics. That is why KDIGO emphasizes complementing office blood pressure with ambulatory blood pressure monitoring and home blood pressure monitoring, especially in CKD patients. Masked hypertension is highly prevalent. Almost 40% of CKD patients may appear controlled in clinic, but actually they have uncontrolled BP outside the hospital. And this isn't trivial. Masked hypertension triples the cardiovascular event risk and quadruples the risk for end-stage kidney disease. So, accurate blood pressure assessment is the first step in protecting kidneys in hypertensive patients. Even before overt CKD is diagnosed, we can pick up clues that kidneys are already being affected by hypertension. A history of long-standing hypertension is an obvious risk factor, but there are more subtle markers. Bland urinary sediment with subnephrotic range proteinuria is often our first lab clue that glomerular damage is happening. Subnormal kidney sizes on ultrasound indicate irreversible nephron loss. And left ventricular hypertrophy reflects chronic vascular stress. What's happening in the heart is often also what's happening in the kidneys. Now that we have seen who is at risk and how to detect early damage, the next crucial question is, how intensively should we lower blood pressure to protect the kidneys? Evidence suggests that higher the proteinuria, the more stringent we should be in blood pressure control. Because better proteinuria reduction leads to better kidney outcomes. But we must also be careful. Intensive blood pressure lowering, especially below certain thresholds, can increase the risk of acute kidney injury, particularly in elderly CKD patients with impaired renal autoregulation. So we have to carefully tailor our targets, monitoring for both benefits and adverse events. Let us now look at what current guidelines recommend regarding target blood pressure levels in patients with chronic kidney disease. This is the key KDIGO recommendation that guides our current practice. For hypertensive patients with CKD, if we can measure blood pressure properly using standardized office protocols, a target systolic blood pressure of less than 120 millimeters of mercury offers maximum kidney protection. But if we don't use proper technique, trying to achieve this number based on inaccurate readings may be hazardous, resulting in overtreatment, unnecessary hypotension, falls, and AKI episodes. So the target is not only about how low, but also about how well we measure the blood pressure. Along with blood pressure measurement and target setting, these are the core investigations every hypertensive patient should undergo. Microalbuminuria assessment is particularly important. It often gives us the first hint that glomerular injury has already begun. Fasting blood glucose helps us to detect diabetes early, and we know the synergy between diabetes and hypertension is particularly dangerous for the kidneys. ECG may reveal left ventricular hypertrophy, a surrogate marker of cumulative vascular injury. Checking lipids and thyroid function helps us identify correctable contributing factors. While essential hypertension is common in older patients, in younger individuals, we need to always consider secondary causes, because sometimes treating the underlying condition may actually cure or dramatically improve blood pressure control. Here are the key clinical red flags we must not miss. Difficult to control hypertension, recent worsening of hypertension, very young age of onset, accelerated hypertension with end organ damage, and biochemical clues like hypokalemia, metabolic alkalosis should always trigger a detailed evaluation for secondary causes. This slide really captures the heart of what we are trying to achieve. Yes, we want to reduce blood pressure to target, but that's only one part of the story. Equally important is organ protection, because kidneys, heart, and vessels begin to suffer long before we see clinical events or significant GFR decline. This is why RAS blockers, specific calcium channel blockers, lifestyle modification, salt restriction, and proteinuria reduction all play central roles in our management approach. Our ultimate goal is just not to lower blood pressure, but to prevent the progression of chronic kidney disease and cardiovascular events. With that in mind, let's now look at the practical strategies we can adopt. What is the importance of diet and lifestyle modifications in hypertensive patients with kidney damage? Lifestyle modification remains the bedrock of hypertension management, and diet plays a huge role. The DASH diet, rich in fruits, vegetables, whole grains, and low in saturated fats, has consistently shown significant benefits. In fact, following a DASH-like diet can lead to an average 10 millimeters of mercury drop in systolic blood pressure, which is actually equal to giving a drug or an antihypertensive medication. KDIGO strongly recommends incorporating such dietary patterns in CKD patients to both lower blood pressure and also to protect the kidneys. Beyond blood pressure, DASH also improves metabolic parameters, reducing insulin resistance, improving lipid profiles, and reducing cardiovascular risk. Salt restriction remains one of the most powerful yet underutilized tools in hypertension management, especially in India where salt sensitivity is highly prevalent. KDIGO recommends restricting sodium intake to less than 2 grams every day. Even modest reductions in salt intake, if done consistently, can lower blood pressure by about 5 millimeters of mercury, again equivalent to starting a new antihypertensive medication. And importantly, salt reduction not only lowers blood pressure but also reduces proteinuria, slows CKD progression, and improves cardiovascular outcome. So with diet, salt reduction, and lifestyle changes forming the foundation, let's now turn to pharmacologic agents and focus on which antihypertensives offer additional renal protection. When it comes to pharmacologic therapy, both KDIGO and European Society of Cardiology broadly agree on the same classes but differ slightly in their emphasis depending on the patient profile. In kidney disease patients, KDIGO prioritizes ARBs because of their strong proteinuria reduction and renoprotective benefits. Calcium channel blockers are an excellent partner class, particularly when ARBs alone aren't enough or not well tolerated. European Society of Cardiology includes diuretics more upfront for general hypertensives, which makes sense given volume-mediated hypertension is common. But in CKD patients, diuretics must be used judiciously to avoid volume depletion and worsening GFR. Thank you.